I have been following your journey for a little bit, and I've seen you be connected through some of the freedivers I know and just within respiratory therapy. And as a freedive medic, I was like, oh my gosh, like I was so kind of fangirling, impressed by you just because you're doing the things that light me up. And hello, and welcome to Breathe or Die. I'm Danny May with Breath Guidance, and I am here with Leigh Baker, who is a respiratory therapist and freedive medic, and she has been operating in the world of respiratory for quite a while, so I'm very excited to speak with her today. Would you mind just giving an introduction to the listeners where if they have never heard of you or if they are like, who is Leigh Baker? Will you just give them a little snippet of intro of who you are and what's important to you as far as breath and breath education is related?
Well, who I am. So first and foremost, my day job is a respiratory therapist, Monday through Friday. I've been in respiratory therapy for, wow, how many, like 17, 18 years now. I work at a little hospital in the Pacific Northwest in a little town called Gig Harbor, Washington. It's cute as can be. So I worked at that hospital since the doors opened. Not many people get to do that very often in their careers. So I've been there since the very beginning. And I've done all kinds of different types of respiratory therapy. And now actually I do run the department, which is kind of fun. It's a lot of administrative stuff, but I do still get to take care of patients, which is really great, which is my passion. I love taking care of people. And respiratory therapy is very interesting field, very necessary position in the world of healthcare. And we take care, we always say we work navel to the nose, but it's a lot more than that too. I think respiratory therapists their necessity is that our specialty is breathing and everything lung related. And that goes in with the respect of emergent situations. We help people when they can't breathe, and that we get them breathing better. You can save a life with getting them breathing again or breathing better. So it can be a little adrenaline driven. And then we help them along if they just have kind of a chronic condition or if they're in the hospital, and we just help them with medicines and different things like that. So with my experience as a respiratory therapist and very lung focused, I fell into the job of a freediver medic. My friend was doing it, and he was a nurse, and he was retiring, and he wanted to travel the world with his girlfriend. So he asked me, he goes, would you want to provide medical care at a freediving competition? And I said, what's freediving? So my husband and I got asked to do it, and we're always game for a pretty good adventure. So looked it up, studied about it. We're like, well, this sounds like fun, and it was an awakening. It really was. The introduction to freediving was fast and furious and kind of scary, but it really opened up a field of medical care that is remote and different and outside of the box of what I work in, and so I love it. It's been so fun. And I primarily have only focused and really worked at Vertical Blue down in Long Island, Bahamas, but it is a challenge working in the Bahamas on that island. And it's a big production that we do. It takes a lot of planning to get there, but it's so worth it, and it's fun. The divers are amazing. They're inspiring, and they just really remind me of how the ability for the human body to put itself through the tests of depth and, apnea and come out fine, and yet the fragility of the human body and how it can be affected by depth and apnea. So anyway, so that's that, and that's who I am. And when I was coming into this, I was like, well, I may not be the right person for the breath work, because my work is all about making people breathe, not really breathing myself or, teaching them how to breathe. But I've got a different kind of slant on it.
So it's fascinating because when you hear people talk about their breath, there's a couple of different commonalities that I usually hear. The first one is if people are sick, do they have an pneumonia? Do they have COPD? Are they having asthma? Like something that's going on with their breathing mechanics or the physiology behind respiration, where a lot of people don't even acknowledge their breath or their breathing until there's something wrong with it. So that's kind of like the first thing that I usually hear from people is when they start to look at their breath. The second thing is when they're getting into meditation or mindfulness, and the breath has been used as this technique to be able to bring people into the present moment, to bring a little bit more conscious awareness to themselves and use the breath as a tool for that. And the last thing I always notice is athletes, when they have done all these things to perfect their diet and their muscles and their flexibility and their sleep and their nutrition, and they go through all this, and then they finally get to where they think, breathing is something that I could probably train to perform better. But it's fascinating because you were in the world where people were going to need your help for breathing conditions. And then you got into the world of the one performance based sport, right? That is like totally centered around breath or the lack of breathing and training how to do that better. But I just think that it is so cool because as a respiratory therapist and as someone who is helping freedivers stay safe, right? That sole focus on the breath and being able to help people breathe, I think gives more of a highlight to maybe other athletes, right? Maybe a climber who's going to train for alpine acclimation, or a runner who wants to have better breathing mechanics as they perform for a race or something like that. But also to the people who maybe are totally healthy. They're not an athlete, and they might not have asthma or COPD or something, but they're thinking maybe now a little more of, oh man, how am I breathing? Do I have a dysfunctional breathing pattern? Am I even thinking of something as like air quality? Am I in a space where I'm breathing in microbes that might not be the best for my health, so on and so forth? So I really am. I'm impressed with you and what you're doing, and I just love to see more people care about their breath, you know?
And I agree. I recently had a great conversation with a friend of mine, and she's a freediver and she teaches yoga. And we were discussing how our society anymore is a very anxious society. It really is. And so we forget to breathe fully, to breathe all the way down into our diaphragm. And we're always just like breathing from the very tops, like because it's just such sometimes a very tense environment. We forget to relax and forget to really take big breaths because it's huge, it's important. And I think those of you like yourself who is dedicated to teaching about a full breath, and different people who do that, there is such a benefit at taking deep breaths, is really breathing into your chest wall and for the relaxation, and it works, it really does. And so I think, like you said, think the masses, we forget to really breathe fully. We get going in our lives so fast and furious, and we forget to take those big breaths. And so I think the work that you're doing is fantastic because it reminds us all to do the right thing, and to breathe deep, because it's better for you. It's better for your lungs, better for everything.
So I'm curious, since you work in the hospital with people who have breathing related conditions, and then you also have worked with freedivers who are, I assume, at the tip top shape of their breath health, or at least have trained to be that way to perform, what are some of the differences in assessments, maybe like heart rate, lung volume, like different things that you really notice, like when you're at the hospital and you're working with those types of patients versus when you're at Vertical Blue and you're working with the freedivers? What are the biggest differences that you notice?
That's a great question. In the hospital, my work revolves around keeping people breathing. We do not want them to be apneic. Our whole world revolves around, like, you have to stay breathing. And so whether it be an emergency situation or just we're just taking care of them in the hospital, or our whole assessment of that patient is that, how is their breathing looking? Do they have more work of breathing? Are they using accessory muscles to breathe? What's their saturation? The little oximeter on their finger. How do their lungs sound? Even if they do sound funny, what's going on? How can we fix it? And then we go so far as doing blood tests to make sure that their blood chemistry is in alignment with proper breathing. So what we do is an arterial blood gas, and it tells us the pH and how much CO2 and O2 that you have rolling around in your system right at that time. And so our job is to keep those numbers right in the normal range, and that differs, a lot with freediving. So the contrast is, in the hospital, we prevent apnea at any. We cannot have them apneic at all. Whereas in the freediving world, apnea is what they do. Everybody's response to apnea and their adaptation to it is very different, and it's very personalized, and they train for that. They're amazing athletes. They, train throughout the year. They have their different training methods, and they train in different places for different things. And so with a diver who is doing a performance of a big dive, my assessment really doesn't change that much, but I do acknowledge that. So they're apneic for a good couple minutes. And then when they surface out of that water, I do not take my eyes off of them until, as I watch them breathe, watch them breathe, watch them breathe. I mean, I'm assessing as I'm watching, and that tells me a lot about how they're doing. A lot of it, with those athletes, when they're coming out of their dive, it either goes one way, which is good, or the other way, which they either black out or they have a little lung squeeze, an emergency of some sort. So when they come out of the water, that's what I'm looking for. Are we going one way? Or are we going another? And then if we do have something happen, I do really a lot of the same things. So I assess how their work of breathing is, what their oxygen saturation is. I take a listen to their lung sounds. And then if there is something funny in their lungs, if they sound strange, then we treat that appropriately. And same with oxygen, give them oxygen if they need it. So it's just a different, I think the treatment modalities are very much similar. It's just that in the hospital world, no apnea is allowed. In the apnea world, apnea it happens all day. And so it's just different. But yeah, it's fun. It's a pretty cool thing to see.
And for anyone, just in case, if someone is listening, they're like, what are they like? What is apnea? What does apneic mean? Can you just give them like a really simple definition of what apnea means?
Sure. It's just you're not breathing. You're just holding your breath. That's it. So so the apnea is like the no movement of any breath through the lungs. It's like like a stasis type of situation where there's no gas exchange happening per se from the outside to the inside. And there's just basically no ventilation happening. So they're just holding their breath.
I think for most people, if they have never heard of freediving and they've never heard of the practice of apnea, maybe something that they have heard of is something like sleep apnea. That might be more familiar to them in common culture. So I'm curious in the sense of when you are on the platform at Vertical Blue, what are some of the most common conditions or complications? So again, for people who aren't familiar with freediving, they have no idea. They've never watched a competition. They don't really understand what complications could come from when you're diving that deep underwater. When you're saying when you're listening to their lungs or, testing them and assessing them in other ways, what's something that you're trying to keep an eye out for?
So in the world of freediving, there's three big things that we look out for. The primary one is a blackout, and that sometimes is seen, it can be seen way down deep underwater. It can be just at the surface, just below the surface, right when they come out of the water. And so what has happened is a lot of times the majority is just that they're so hypoxic that the brain needs the only thing it needs in the brain is glucose and oxygen. And if you have a lack thereof of any of those two, you're going to pretty much pass out. Your brain does need oxygen. So they can just start to pass out. And they can run out of gas underwater, like I said. And pretty much if it does happen, when you can see it on the surface, they call it a loss of motor control, LMC, and they get the shakes, they get that faraway look and everything else. And it's just the brain has not caught up with physiologically the body. It needs oxygen in the brain. In addition to, a lot of times a blackout can happen from just the blood shift. There's a huge amount of physiological shifting of blood in the body during a dive. And so sometimes that just doesn't quite get to the brain, and then boop, out you go. So blackouts are they can look very scary. They can look horrible, and they're like, oh my God. But they resolve very quickly. Normally, it just happens. Maybe they're out for maybe a couple seconds, 10 seconds, 15 seconds. We get them over to the platform up on the deck and give them some oxygen, and pretty soon they're right back to where they were. So we look at that as just a situation that happened. We give them a day off and make sure that they're okay. Just evaluate them, and then they can dive again, because it is just a thing that happens. It's just a very natural response for the body to want to kind of black out when it's not enough blood in the brain. The second thing is a lung squeeze, and that is a lot more concerning than a blackout. So, what happens is your lungs are this amazing network of thousands and thousands of thousands of little teensy tiny balloons. And they're called alveoli. And your alveoli have a capillary bed around them of blood. And so that's how we diffuse oxygen and CO2 all day, every day of our life, in and out. So, with this amazing network, when the diver goes under, they have a certain pressure that when they pack it, sometimes they'll put extra air, air into their lungs to equalize, but they also have a natural pressure inside their lungs. Well, as they go deeper, that pressure from the ocean, from the water is pushing on the chest wall, it's pushing on the body. So you have the effect of the mammalian dive reflex where the body begins to shunt blood from the different areas and it brings it to the core. And that's just a natural thing that it's doing. So as they go deeper and deeper and deeper, the pressure gets more and more and more and more. And so that's where the divers train to be able to adapt to those pressures. Well, when they turn around and come right back up again, now the pressure's lessening and lessening and lessening and lessening. And so there's going to be, rather than compression of the lungs as they go deeper, now they're starting to expand again. So when that expansion happens, there could be a little bit of blood that leaches from the alveoli system into their airways. So when they come out of that water and they take that first breath or two, they'll sometimes cough up a little bit of blood. And so sometimes it can be a lot of blood. Like it can be very foamy. It's pulmonary edema, basically. That's what it is. So we take that very serious. And typically when we listen to their lungs, they will be very coarse. You can hear the fluid. In fact, you can even put your hand on their back, on their wetsuit, and you can just feel it run, just rolling around in there. So we have different ways to treat it. We provide oxygen because typically they will be very hypoxic, meaning that their O2 saturations are very low. They don't look too good. They're very tired. They're fatigued. So it's a whole thing. We treat it in certain ways, and we put CPAP or BiPAP on them to help them out, to help that breathing. And so yeah, and after that, then we watch them very closely to see if they can dive again for that competition. Sometimes they can't, depending on how severe of a squeeze it is. Sometimes they can't, but sometimes if it's early on, then we'll let them dive a little bit further on into the competition. But we take the lungs very serious. The third one is a decompression injury, basically. And freedivers don't have, unlike scuba divers where they come up too fast, they get the bends. You can have some paresthesias and all different things. Divers can have severe ones, but it's not to the degree that scuba divers have. Sometimes they can be a lot more mild. But other times, other divers where if they dive repeatedly, they've found that if you dive over and over and over and over and over again, you run the risk of having a decompression sickness injury happen.
Is that over and over in the same day or like over and over in a lifetime?
And just like in a training session, for instance, if you dive 5 times on one day, 5 dives on another and another and another, you're not taking breaks and resting. It's kind of a repeated thing. So yeah, they can have some pretty severe, they can have, paralysis, or like aphasic type of things where they have trouble speaking, memory loss. And so the treatment for that is a hyperbaric chamber. And that's the bummer part about the Bahamas is there's no hyperbaric chamber close by. The closest one is the United States. So we try everything under the sun to prevent them from having a DCI injury. So, but it does happen sometimes. So
When people think of the bends or decompression sickness, I know that they're thinking about the nitrogen. Do you find that these freedivers, does anyone come up with the nitrogen narcosis where they're feeling, a little maybe not all the way with it?
absolutely. And nitrogen is a big thing that's, it's, we talk about it, but it's mostly we see, like you said, we see more the signs of nitrogen changes in their system. They'll come up and act a little goofy, or they'll say, some of them have said they see panda bears underneath the water, little hallucinogenic type of things, and they come up narked. That's what they call it. They felt like a little bit narked. And what I've realized is that knowing some of these divers throughout all these years is that I understand that some divers are more prone to narcosis of a nitrogen component than other stuff, versus they're more narked nitrogen wise than they are hypoxic. So it's something that I kind of recognize after a while, and the nitrogen and the oxygen and that are all shifting so much in the body when they're diving so deep. So it is a very common thing to happen.
Do you find, so when you say that some divers are more prone to the narcosis than others, do you find that there's also maybe some divers that are more prone to blackouts or more prone to squeeze? And if you do, have you been able to identify or have an idea of the identification of like why those particular divers are more prone to those conditions?
Well, I think as we all see, like, for instance, when the competition starts, there is a little bit of a histrionic component where we talk about like so and so. We got to watch out for this person because he squeezed in Roatan last year pretty bad. So during this particular dive discipline, and so we don't put a whole lot of stock in that. It's just an awareness type of thing because the divers are very aware of it too. And so they really will try to improve their technique with that discipline and to not squeeze or to not black out. So they're working on their craft, very well. But the one thing we do notice is that in the particular disciplines of like CNF and, free immersion and constant weight and different things like that, the instance of a squeeze is greater when they're actually pulling on the rope. They're pulling themselves down and then pulling themselves up because it opens up the chest wall and it really stretches. And so education is just is provided, if we can, to say, hey, don't take such a huge reach because keep it controlled so you don't stretch your thoracic cavity that much because the chest wall is very sensitive to slippage and to shearing injuries. And so when you stretch it, you're pulling on that lung tissue. And so it doesn't like it and it gets a little angry and it gets irritated and then they'll squeeze. So it is, kind of a common finding, but we see it mostly in different disciplines. But yeah, pretty much the divers, if we see it early on, for instance, if one diver is blacking out on a particular dive, and we'll kind of watch them, they'll try the dive again and again and again, and we'll see that it's just something's sticking with them that's not letting them come all the way up fully conscious and alert. So
Does a diver know when they have a squeeze? Like, is it like, because I've heard two different kind of accounts as like some divers know immediately and other divers are like, oh, I couldn't even tell until I was like coughing up blood or something like that. So is there, yeah, like, are they usually going to feel it when it happens?
yes and no. So when they come out of the water, I've never really heard anybody say, I felt it when I was down there. I really felt it. I felt something was wrong. I've never really had anybody say that. But afterwards, they said, oh, yes, when I came out of the water, got up on the platform, I felt it. Something was amiss. Something was wrong. I felt tight. It feels heavy. Yeah, I can taste it, different things like that. Or they'll just say, and spontaneously, they really have no control over it, is they'll cough up a bunch of blood. And it takes them by surprise. A lot of times they're like, oh man, wow, and divers are pretty sneaky as they'll try to hide it too, So I love them. I love all of them. I truly do with all my heart. But they'll like, and they'll put it in the water, And so that's why my eye is on them. I watch them and watch them and watch them just to make sure. But because I just don't want them to dive if they're injured, that type of thing. I want the best for them and to go on to diving more and more and more. But but as far as like blacking out, yes, they do know when they after if they black out underwater, if they come, a lot of times if they black out on the surface, they will have a real disoriented look like, Oh no, I did black out, didn't I? Wow. Um, that's more of a surprise when it's on the surface. When they're down below, they'll say, I was running out of gas. I knew it. I was running out of gas, but they don't remember the process of getting drug up. Your brain has a really good way of kind of turning itself off and providing a little bit of a retrograde amnesia type of thing. So, but they do remember that feeling that they have.
When I was taking my free dive courses, I've heard of two different kinds of barotrauma or squeezes where both for the lungs and the sinuses, where they were talking about there is a squeeze that you have on the descent and then a squeeze that you have on the ascent. And then also, I think for the sinuses, they called it like a normal sinus squeeze as you go down and then a reverse block as you go up. Are you able to speak to the differences between those?
Yes, I'm not real savvy, in all honesty, with the whole sinus block thing. I've never really understood it. I mean, I understand it just because the pressure changes, even though the effects are happening in your lungs, they're happening all over your body. They really are. And so your sinuses are going to get affected. Your trachea can be affected. Your organs are going to be affected. So it makes sense that, that if you do have on descent or ascent, you're going to have the compression of the pressure, increased pressure, as you're going down, and then the re-expansion as you come up. And so your sinuses, being that they're like little cavernous little spots all over your, in your head, you've got little parts and pieces, that they're going to stick shut, and sometimes they can not pop open right away. So that's a very common thing to happen, is that they have a stuck sinus to a certain degree, and it takes a little bit to pop it back open again. But your ears are the same way. But it's interesting how the freedivers, because they equalize so much through their sinuses and their ears and their eustachian tubes and everything, they become very fluid and very flexible. And so part of their training is that they, with that extra pressure, going down and up, and equalizing, they get very used to it, and so their body becomes more acclimated to the changes and are able to fix themselves to a certain degree. So I hope that answered your question. So
Yeah, absolutely. And kind of moving over towards the hospital sector in the sense of as an RT, what are kind of like the most common conditions or complications that you find at the bedside as people, if they're going to call an RT to, come and help and need assistance, what are like the main things that you usually see people coming in that need your help?
well, it really depends on. I mean, it depends on kind of where you work. For instance, I work in a little community hospital, and our patient population is quite old. We have a little, it's like a little bedroom type of community. So there's a lot of old people in our town, and so we see a lot of geriatric patients. I remember looking at our census one day, and the youngest person was like 59 years old. And it was all older people. So we're really good at taking care of these older folks, and they come with a host of all kinds of lung problems. And so it's just out of ageism. They have like COPD, CHF, congestive heart failure, all kinds of things. But then again, we do see the younger people with asthma. And we have some new conditions out called interstitial lung diseases now, which are really kind of the junk drawer diagnoses for like asbestosis, pulmonary fibrosis, and they're autoimmune, and they run. A lot of it is women who have them, but men have them too. It can be industrial induced and stuff. But anywho, the primary thing that we see when we're called to the bedside is that someone is profoundly short of breath, and we got to fix it, and we got to do something for them. So we utilize a lot of different tools. We can put them on, of course, oxygen to help them out if they're having an issue with that. Secondarily, we can do high flow oxygen, which delivers a ton of oxygen in a really fast way, very accurate. And then we can put them on some non-invasive positive pressure, which is like CPAP or BiPAP, which really works well to make their breath bigger so they can breathe easier. And then the last thing is that if they truly are so decompensated, we'll intubate them and put them on a ventilator. And so, as a respiratory therapist, we run all those machines from the ventilator down to the oxygen, and it's a lot of kind of nerdy numbers that RTs kind of play with. They deal with flow and trigger and volume and rate and blah, blah, and gases and gas exchange um, and so that's pretty much it. When someone can't breathe, it's scary. It's scary for the patient, and it's scary for the bystander, the nurse, and it can be scary for the RT too, because it can go sideways really fast unless we can intervene and get the treatment on board pretty quick, turn them around better. So yeah, that's pretty much the hospital bedside stuff. In addition, we do like all kinds of stuff. We do pulmonary function testing where we can see how big. We measure the lung mechanics, how much volume they can take in, but that's used to diagnose different conditions too. Bronchoscopies, we send little cameras down, all kinds of stuff. Our little hospital, we even do EEGs where we, put the stuff on people's heads looking for brain waves. That's just another little thing that we do. Um, so, so yeah, it's a big window of stuff that the RT does for kind of a very specialized job.
I find it fascinating because I love the numbers. I love data. I like to see like what is actually going on. What's where are the complications. So I'm in school right now working towards a respiratory therapy program just because I'm fascinated with it and I want to learn more and I want to understand as much as I can about the lungs and the heart and just the way the body operates. And one of the things I've been learning is because I follow a couple of RTs on YouTube and they go through different case studies and those kinds of things. And one of the things they talk a lot about are COPD patients, where they'll have these numbers of their pH and their bicarb and their oxygen, and they'll talk about how if you saw these numbers with a patient who didn't have COPD, then you'd have a big problem. But if the person has COPD, you'll look at these numbers and you think like, oh my gosh, this person like can't breathe, they're dying, something's wrong. And they're like, oh no, 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 they just have COPD, they're fine. Can you kind of speak to that? Because I thought that was really fascinating.
Absolutely. Well, first off, I hope I mean, you can cut this out, but I didn't know you were in an RT, you were wanted to be an RT. I don't know where I must have lost that information someplace, but I didn't know you were interested. That's so great. I'm so happy. I'm so proud of you. Yay. We need good people like you out there. Um, anyway, okay, carry on. So yes, so when you look at an arterial blood gas, and you, COPDers and different people with different types of situations, especially COPD, they all kind of look a little bit not the same. That's not what I'm saying, but they kind of follow a very similar pattern. And the one thing you do learn in RT school is that your pH has to, when it stays in a certain normal level, 735 to 745, it means you're compensated. And so based on COPDers, because their lungs are injured and they are damaged from long-term smoking and they just don't have compliance. Their expansion and recoil is gone. They're like grocery bags just flapping in the breeze. They will constantly retain. They'll retain CO2 and retain it and retain because they can't blow it off. So that's their norm. That's their norm, was to have, rather than a CO2 of like 35 to 45, there's like 50, 60, 70, where most people, like if you or I had a CO2 of 60 or 70, we would be unconscious, like on the floor. So, but that's their norm. And that's, even though their pH is compensated in the normal, but yet their CO2 is not normal, it's way high, they're compensating for what their normal is. And so that's the difference. And then their bicarb as well, because the bicarb, you have just two buffers, and one is the lungs and the kidneys, and the kidneys take a long, long time to buffer. So their bicarb, which is kidney related, it takes a long time for it to do its buffering. So typically they will have a very high bicarb. And it's funny, the docs will say, "Okay, we got to fix this. We just have to bring down their CO2." But we're like, "No, no, 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 no. They're in the normal. This is normal for them. If we do that, we will break them even worse." So we're always kind of fussing with the doctors about that. But that's where they live. And, we call it like the 50-50 club. With their, CO2s are 50 and their PO2 is 50. That's just them. And it's just how their body has adapted to their medical condition.
So I learned more about this because what I do is, if I have like a private client, I'll do a breath assessment, and the breath assessment goes over their breathing mechanics. So I'm just seeing like, what are you running neurologically? Are you breathing more through the chest? Do you have flexibility and strength through your diaphragm? Can you access more space in your back or your intercostals? But then I put the pulse ox on them, and I run them through a couple of different breath holds. I run them through a couple of different breathing techniques. And then we do a simple like BOLT score, so body oxygen level test, to see, okay, what is your CO2 tolerance? Because both in anxiety and stress and free diving, we talk a lot about carbon dioxide tolerance. And I remember my first COPD patient having like this huge tolerance for carbon dioxide, but everything else wasn't, like their breath capacity wasn't. I was very confused. I was like, how would you have this tolerance for carbon dioxide, but yet again, when I would originally think of tolerance for carbon dioxide, I'm thinking of a free diver. I'm thinking of someone who has trained and trained and trained. So can you kind of speak to that and the difference of maybe a free diver who's working on their carbon dioxide tolerance, and then maybe a COPD patient who has just acclimated this tolerance for carbon dioxide over years?
hmm So, so with the free diver, this is one thing that my other, some of my all my colleagues, we always talk about this. And I have an RT friend that I took with me a couple times down to Vertical Blue, and we always scratch our heads sitting on the beach, like, okay, what's going on CO2 wise in there? What? So, and I'm not I mean, I don't, I've never done testing on the free divers when it comes to the CO2, but here's my just generalized thought is that, so the free dive athletes, they are in great shape. Normally when they're walking around, they are ventilating, oxygenating beautifully. They have great lung mechanics. They are at the peak of their health. Um, so when they do a deep dive and their CO2 might go up a little bit, but I think because they're in such great shape that we don't see the effect of hypercarbia to the extent of like a COPD patient. I don't think my thought is that their CO2s don't rise that much during a dive, and then they normalize as soon as they take that breath that they come out of the water. It's normalizing. It's already normalizing so quickly, and it comes right back to normal again. So they're running on a very normal CO2 range, and their ability to compensate and to get used to a little bit of a change in the CO2 rise, even if though it's small, they're still very used to it. And the divers are great at adaptation to that. Now, the COPD patient, through the years of either smoking and the progression of lung injury that they have, with the alveolar walls, and they're not compliant anymore. That right there, they live on it day to day, just working, and it gets worse and worse. It doesn't get better. And so, because every single day it's a struggle to breathe, their CO2s are going to rise because they can't exhale fully. And changes even in their blood, they become, polycythemic. Changes in their blood products even change a little bit to compensate for this. So I think the difference between free divers is that they dive for just a momentary time of hypercarbia, even though it's small, but yet that COPD patient is walking around their whole life with hypercarbia because they just can't breathe. Their lungs are damaged, where the free diver, their lungs are intact and they're healthy. So there's just a difference in it. A lot of it's just mechanical as to how their lungs are doing. So I hope that helps.
Yeah, and I'm curious, so I had a friend who asked me because I told them I was like, "Oh, I'm coming on with an RT and I get to connect with her and ask her some questions." And one of the questions she asked me was, "Is there anything that someone could do if they have, I think it's I might not get this pronunciation right, but thalassemia, where the carrying oxygen capacity of the blood is lowered." And it made me think of also people who, want to climb these 8,000-meter, like a Mount Everest or something, where most of them, if they're going to survive it, they have to breathe in supplemental oxygen. So can you speak to that in the sense of people who might have a oxygen carrying capacity condition with their blood, or maybe even someone who's going to an elevation where their blood isn't going to be able to carry that much oxygen? Like, are there things that people can do to be able to fix that or treat that?
That's a really good question. And wow, if it's a known situation where you have the a lower oxygen carrying capacity, if you have a condition, I would even be very, very careful to going to height or to depth, because it could really pose a big problem. The only other thing that, I mean, if they had a real big drive in doing this, is that, you can go on different types of medicines that improve your oxygen carrying capacity. And those are the epoprostanols and different things like that. Now, in the world of freediving competition, they're highly, highly, you cannot use them because it's cheating. But if you're going hiking in the mountains and it's something, a passion of yours to do, then yes, you could probably take these. But you have to be pretty sick to go on these particular medications. But if you had a condition where, the thalassemia was in play, it would be it'd be very, be judicious as to where you're going and what you're doing. But and then that's the thing, is hematology is not my forte. So I would think I'm curious if you could actually train and kind of get your blood oxygen carry capacity better, if with this condition, just by acclimating at different heights and depths and different things like that. I don't know, I've never had a diver ever come, have that condition before, so that would be very interesting.
I had a client who had, I can't remember the type of anemia, but he had some type of anemia. And he was noticing that because I do a breath teacher certification where I teach after they go through, I have an online training. So I teach them like 60 different breathing techniques, and then they experiment with all of these to see how the breathing techniques make them feel. Because I like to think of breathing techniques similar to certain prescriptions, in the sense that maybe for two people with the same anxiety, they might take the same medication, and for one person, it works really well. And for the other person, they're like, this isn't helping my anxiety, or I need a different dose, or I need something. So, because of people's breathing mechanics, oxygen saturation, heart rate, CO2 tolerance, all these things that are going on, the breathing techniques might affect them differently. So, he went through that, and then he came into my breath teacher certification to teach, and we go into advanced practice of all of these different breathing techniques. And what we noticed was the way he felt after particular energizing breathing techniques, where we kind of get them to hyperventilate a little more, they're really gassing off a lot of carbon dioxide, he would just shut down, where other people would go into more of an energized state. And it was so fascinating. And so we talked more about his anemia and blood carrying and oxygen carrying capacity and all of that. And it's just something that I'm on a mission to find more data and do more research, because I really believe there's a lot in the way that you were talking about how the kidneys take so long to find a homeostasis throughout the body, but the lungs can do it so quickly. But I don't find a lot of research or data on these types of breathing techniques and what they're really doing, one, to particular healthy individuals who don't have any conditions, but two, to people who do have certain conditions and are noticing either bigger benefits or maybe bigger contraindications with particular breathing techniques. So I'm curious, do you know, because I know freediving is one of the places that I'm able to find more people willing to invest in research and data and science behind breath training. But do you know of any particular, yeah, like places or science or labs or maybe people who are really trying to find this type of study?
Unfortunately, I kind of don't. But I think that what you're doing is such a necessity. It is so 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 needed in the world, in our medical field, as well as the different, like for free diving, different things like that. And the only reason why I say this is because more often than not, and I just barely touched the very tippy top of that big old iceberg of what you're working on, is that, like I said before, we're such an anxious population these days, and I have treated more. I should say not treated like as in just talking to people, anxious people, and the anxiety comes from, whatever is going on with their life, but anxiety. Brings forward such a huge component of shortness of breath. I can't breathe. Can't take a breath. I'm going to die. That impending doom. And so bringing it down and saying, okay, relax, deep breath in, let it out. Just these breathing techniques to try to calm people down. I think I mean, we all do it. All the RTs we were just talking about it the other day, is that we feel like we're almost bartenders sometimes, because we're listening to people and take a deep breath in, relax, you're okay, it's going to be fine. We're trying to calm people down, calm, by the use of breath. And it works. It really does. It helps tremendously. Now, you get those outliers that require like some anxiolytics and stuff like that for, medications for, anxiety. But because it can really, if you have a patient that is has a breathing condition already, it can blow them right into an exacerbation of some sort. So we really try to pull them back, calm down. But as far as studies go, I am so sorry, but I don't really know of any, because I don't think that particular, as important as it is, it hasn't reached the medical field that I know, in the way that it should be. I think it should, more focus should be on it, and we should be doing it more often. And the one thing that surprised me is that, like I said, the RTs at where I work, we do EEGs, and the one test that we do is a hyperventilation test. And so we make them hyperventilate for 3 minutes. And the idea is that if people are prone to this, it will fire off a seizure. And I've never seen it happen, to where they've had a seizure, but it can, if they are particularly sensitive to changes in their CO2, especially in their noodle. So it's really interesting how fast breathing, slow breathing can really affect the brain in different ways. And it's just very interesting. Yeah, it's a very interesting thing that we do. So.
I love that you shared that, because made me think of a couple of things. The first is that my breath technique training, which is my online program that teaches people 60 different breathing techniques, it's finally approved for CEs, continuing education credits for nurses. And part of the thing that I had to go through to do that was to get all of these papers and resources, and it was so hard finding some of this data and research that explains what's happening in the body with the breathing techniques. And I have two pillars to it, in the sense that, one, the nurses can take this course and they can give it to their patients. They can give it to the patients' families who are having these anxious responses to what's going on in the overwhelm. But also, the nurses themselves can use it when they're in between codes or calls or patients or whatever's going on. So it's really a two-pillar program of like saying, hey, these breathing techniques are going to be able to serve your patients better, improve patient satisfaction, but also, two, they're going to make you hopefully feel a lot better and more resilient within the work that you're doing. But the other thing that you said that really made me think was, one of the most popular forms of breathing techniques nowadays, at least where I come from, it from the yoga wellness world, is breath work, in the sense of people laying down, they're hyperventilating for about 2 hours. And a lot of these breathwork facilitators are not educated on blood gases. They're not educated on what is going on with people with contraindications, such as neurological conditions or cardiac conditions. And it's a little frustrating as a breath teacher, myself, because I hear people come into my trainings, or I hear people as students who have gone to other breath experiences or events, and a person will ask a question as far as, why their hands get, locked, and somebody will say like, "Oh, you're just holding on to energy." And it makes me sad and frustrated because it's like, okay, that might be true in an emotional state, right? But really what they need to know is physiologically what is going on with the gas exchange, and why these people are having these physical responses to the breathing. So, and that was one of the things too that we talk a lot about in my breath teacher certification, is these types of breathing techniques can cause people to have seizures. They can cause them to have all of these other results, unexpected results, and you need to be trained at least at a bare minimum to understand what's going on. So when you do call emergency services, what you have to tell them, so on and so forth. So I'm really glad you brought that up, because I had a nurse anesthetist in one of my last breath teacher certifications, and she was talking about that, how she'll test certain parameters before they put them under anesthesia to see, are they going to have a seizure or something like that. So I'm really glad that you brought that up.
And it's really interesting how you're right. The classic. I always, when I teach, when I do teaching of any type, to other medical professionals, when we're talking about ABG, different things, respiratory alkalosis, and that's exactly what the hyperventilation is, where they get the carpal pedal spasms, and it's the classic, like the little girlfriend just broke up with her boyfriend and she's crying, and so, and they're like, I can't feel my face. Oh no. And that's, yeah. So, but you're right. It's, yeah, the training. Yeah. It's great to have the train to know when you know, what's going on, you fix it, and it's easier to fix, you just fix the issue. But it's interesting how, you know, when I run a ventilator, we draw blood gas and we dial in that ventilator, because we're controlling the patient's breathing, every little bit of it. It's amazing how fast we can get that, depending on the situation. Sometimes I say to myself, wow, I mean, we've got this respiratory rate set so high, and if you or I were breathing this fast, we would be so sick. But it's what the patient needs for the situation going on, and it's quite amazing how, we just dial it in, the body knows how to respond to it, and then it gets better in time. So pretty interesting.
So when you're ventilating somebody, and I don't know what I don't know, right? So I haven't worked on any ventilators or anything like that, but I'm curious because from my understanding, medical literature will say that the average respiratory rate should be between 12 to 16 breaths per minute. So when you're, calibrating people's breathing rate or watching their breathing rate, is that like, what number are you looking for to say, okay, these people are in a good spot? Or what number is the number of respiratory, or the respiratory rate where you're like, uh-oh, something's not right here?
So typically, what we'll do is we'll draw a blood gas and see where it's at. And so, really, what drives that respiratory rate is their pH and their CO2, and that's what we're going for. So if their pH is low, then we will, and their CO2 is high per se, we will really turn up that respiratory rate, because that's what changes the pH and the CO2. It'll bring your CO2 down. You have to blow off their carbonic acid, the hydrogen ions. So you blow them off, and so when you blow off that CO2, your pH comes down. So that's why we're chasing gases, as we say, because we draw another one. So we say we put them on a rate of 20. And then we let them kind of marinate with that, draw another gas. Okay, where are we at? Did we kind of get closer to the norm? Did we get them into their normal range? Okay, so it's not, let's turn up a little bit more and see where we find that sweet spot. And so once we find kind of that a normalish range, we'll let that patient stay on that rate for quite a while. So that in answer to the question of a normal rate, they're really, it just depends on their situation and how sick they are and what their gases look like, to how much we turn up and their minute ventilation, all this stuff. But our whole goal is to try to get them in that normalish range of their pH. And then, because like if they're super septic, they're going to be their gases are going to be totally wacky and they're going to be on a high respiratory rate for a while. But as that sepsis resolves and they get better, then we turn it down. And because we don't want to make them alkalotic, so we'll start to progressively turn it down. And then that's when we put them through a spontaneous breathing trial to let them breathe on their own. And typically, when you let them breathe on their own, we want them to be in the range, like what you said, 12 to 16, 18, 20 at most, not too much. They'll poop out after a while to breathe on their own. But when I say breathe on their own, the tube is still in. There's just a little bit of pressure, a little bit of oxygen, just to keep them, but their drive is doing everything else. So, and that determines if we can get them off the ventilator. So, but our goal is to always get them back to their norm.
So when someone's on a ventilator, so a normal person who is breathing without a ventilator on their own, I watch like their breathing mechanics, like what part of their body is moving, what muscles are they really recruiting to get this air in and out of their body. When they're on a ventilator, what's going on with the breathing mechanics? Like, is there any, because I'm like, as the air is going into the lungs, like, is there a lot of movement of those breathing muscles? Are the breathing muscles still getting that full range? Or is it really like more so just the inflation, deflation of the lungs? Like, I'm curious, what's going on with the muscles?
So great question. So when the patient's on the ventilator, of course, we have them sedated. You have to be sedated pretty much to be on a ventilator because the ET tube is in place. So what we dial in is, of course, the rate, but also that tidal volume. And that tidal volume is based on how tall you are, not really how big you are, because your lungs are all, you only have even though like you're 6'7", you have really long lungs. And yet if you're 5'1", but you weigh 500 pounds, your lungs are still only this big, So we ventilate based on height, ideal body height. So with that, so inspiratory in, exhalation out, in, out, in, out. So by normal passive ventilation, the chest wall, the chest muscles are all moving back and forth, and including the diaphragm. The diaphragm is moving up and down. Now, that is a big old thing that we really try to work on, is that as soon as the patient qualifies for a spontaneous breathing trial, and there's certain parameters that they have to meet, we want them to breathe on their own, even if it's for 5 minutes, 10 minutes, 15, they can go for 30 to an hour, because when the patient's on a ventilator and the diaphragm doesn't have to do anything, it's like, okay, peace out, I'm sleeping. Okay, I get someone's doing the work for me. I don't have to work. But then when it comes time to do the work, we got to wake it back up again. And so by having the patient do their own breathing, it fires up that diaphragm again to get it. It's like pulmonary fitness. And so we never, out of the chute, if they've been on the vent for a while, we only expect them to go for a little while, because it's just like when you've been sitting on the couch for a month, you don't want to run 6 miles, you go a little bit, and so we work up to eventually to where they could breathe on their own, for a greater length of time. But again, when people are in ICUs on ventilators, the amount of weakness that happens for the whole body exponentially every day increases so much. And so that's why we really focus on early mobility, to getting people, like if they're awake, getting them off their back, sitting at the edge of the bed, dangle their legs, even stand up, march in place, because their muscle weakness will just incapacitate them to where they'll end up with a trach and maybe on a ventilator for a very long time. So we really, really, really try to get them mobile as soon as possible. So, or that tube out, one of the two.
When you see somebody who maybe has been in the ICU for a long time or intubated where they're not moving, right? You can see the atrophy in their legs or their arms or something like that, but I think people don't think of like the internal atrophy that's going on with their breathing muscles, of like, hey, not only do we not work out our arms or legs or these other core muscles, but we have to get our support of breathing to also, like you said, getting that pulmonary fitness.
Totally. Yeah. They're just, well, I mean, even though it's moving, it's the machine's moving it. It's the patient's not moving it. So it's quite interesting. It's how fast they become weak is just, it's just astonishing to me. It really is. And, we involve PT really fast if we possibly can. Um, so yeah, we try to get them off that vent as soon as we can, just so they can start moving on their own and getting back to their normal place. So because that weakness will just make them sicker and sicker and sicker. It really will.
As somebody who's been in respiratory therapy for as long as you have, and as when I study about respiratory therapy, I always hear what a new field, considering the field of medicine and nursing and all of that kind of stuff. They always talk about how respiratory therapy is more of a newer field in medicine, and working in it as long as you have, I'm curious, one, what is your absolute favorite part, right? Like something that you just, when you go to work or when you see these RTs come in, that you know, like this is going to be a fulfilling part of their job, but also something that maybe has really changed as you've been in. And I'm curious, since you've even said you've been at this same hospital, to maybe help that program evolve, or things that you have seen were working in respiratory that aren't now, or maybe weren't and now are able to work. Can you kind of speak to that, of like what's the best part about being an RT, but also what has maybe changed in respiratory therapy that you've just seen be able to work better, or maybe is phasing out?
Great question. My favorite is I tend to really, I'm a bit of an adrenaline junkie. I was a paramedic before I did this, and so when I come in on a situation where it's like the person, like a cardiac arrest or a real respiratory arrest where it's fast and furious and we got to do stuff like 5 minutes ago, it's just, I love that. I mean, it's stressful, but I just get such a charge out of, and hopefully fixing the situation and helping that person and, hope getting them back, or, I love that part of it. I really do. But I also truly like I think one of my favorites is in the ICU. If we have a patient who's very sick, and there's family in the room, and it's very intimidating for families to look at like all the pumps and the ventilator and their poor loved ones laying in the bed, and they don't understand like what is going in, what's coming out, what's going on, and to try to really explain to the family members, like, okay, let's break it down. Let me tell you exactly what this is and what I'm doing. And these numbers, we're looking at this, we're looking at that. This is what this means, to try to, you know, let them breathe a little bit, and go, okay, all right, it's being taken care of. All right, I get it. It's just we're keeping our loved one alive, and this is how we're doing it. So those are my favorite things. Those, I love that part of it. So some of the things that's changed throughout the years, I even, and I hate to bring the big C word into this COVID, but there really has been a change in how patients are these days to healthcare workers. And they're a lot more aggressive. They're a lot more argumentative. They're a lot more opinionated. And not saying that you didn't have an opinion before, but healthcare violence is at a peak, and I hate to see that. I really do. I've had some of my RTs assaulted by patients. Nurses are getting assaulted, and I don't know. Is that where COVID did it bring us to this point? I really don't know. Would we have been here anyway without COVID? I don't want to blame it on COVID, but that's kind of the marker that we see, that where it started. So that's the unfortunate part, where the healthcare worker is not looking, is not, I guess, not in the same place that we were before. We're looked at a little bit differently. um I just hope it's getting better. I hope it changes, but I don't know. It's just a different world anymore. It really is. So
I've definitely heard of the patients being aggressive to the nurses and stuff like that, but I didn't know it was happening with RTs as well, because again, I haven't worked in the hospital setting. I've tried to do as much research as I can, but from my understanding it was always more so the nurses that are dealing with more of the day to day, the in and outs, those kinds of thing. And then I heard a lot about if people had mental disabilities or mental conditions, like that's where they might not have the wherewithal to be as nice and respectful and so forth. But so you're saying you're finding not only is it the nurses that are experiencing the violence on healthcare workers, but also people who maybe don't have mental illness, that they're usually a normal operating person and they're still being violent to even the RTs.
Absolutely, absolutely. When it's
Wow.
almost like, how do you explain it? So we're telling you the treatment regimen that we're following to get you better, to get you home so you can go on with your life. Well, if they don't like that, they're real quick to say, no, we're not going to do anything like that. And then the little bit of the fight is on. Not that the nurses are fighting, or the RTs are, but there's just this defensive thing about some people these days. And I don't know where kind of it comes from, but just the other day, just yesterday, one of my RTs extubated a patient, and the patient just picked her cell phone up and threw it at the RT, just out of don't know why. Right after tube came out, she picked up her phone and threw it at her, and didn't hurt her, but still, it was aggressive enough of a gesture that required some intervention. But so I don't know. You're right. Nurses tend to get it more because they're in the room a heck of a lot more than we are. But we're in there too a lot, and especially when people can't breathe, they get scared, and then that's where a lot of the outward aggression can come out as well. Sometimes, but it's just a different world out there anymore, sadly.
Yeah, I think it's so unfortunate because I think what, at least in my opinion, again, I only know what I've been exposed to, but what I have heard is there's a lot of doubt in modern medicine. I think there was more trust, blind trust of like, hey, you have my best interest in mind. And I don't really even think, and this is again just an opinion, but I don't even think it's so much medicine that has just destroyed the trust of the general population. I think corporations and government and like all these different places where people have felt betrayed, that they're just a little more weary. And it's so sad because every nurse, every RT, anyone in healthcare that I have ever met or spoke to, they have so much knowledge, so much education, so much experience. And more than that, they have this resilient heart of grace that just shows up every day to take care of people, strangers, complete strangers they have no emotional investment in, to say, hey, I'm here for you. I'm even putting myself in harm's way to take care of you and to keep you breathing, to keep you alive. And I think the more I become exposed to the healthcare industry and community and the workers, I always have had respect, but I have like this whole other different layer and level of respect because I really don't think the general population knows what you all go through, what you show up for. And one of the communities I'm working with is for nurses. It's called Debriefing the Front Lines, and they talk a lot about cumulative caretaking trauma and all of these healthcare workers who are going in and day out. And they, people don't talk about as much of not only patient violence on healthcare workers, but just the emotional toll that it takes to be in that caregiver role day in and day out when it legitimately is, a lot of times life and death situations. So I just want to say thank you for what you have done all these years, because it really is, it's admirable. And I know a lot of people can't do it. So I just went to the dentist yesterday, the day before, and dental hygienist and I've been going there since I was a kid. We were talking, and I told her I was, trying to go into RT school, and she's like, "Oh my gosh, I was an RT." And I was like, "Wait, what?" So she had went and she went through the RT program, became an RT, and she hated the adrenaline. She said that she was when before they had oxygen in the room. So she's like, I'd be carrying pushing this oxygen to the room. She's like, I have pockets full of treatments, and then I'd have to be ready on the drop of a dime to go to a code. And she's like, it just wasn't for me. So she became a dental hygienist. But I think that was something really fascinating because you don't realize, like, as a nurse, as an RT, as all these different healthcare workers, you really have to be prepared at every given moment to help somebody save their life.
Absolutely, yeah. And it's weird. I don't know if it's our where our brain kind of lies. But and I guess I don't know if it's like we get used to it, but when we get that call, like, "Ooh, we got something big coming in," we all go down there with an anticipation of we knowing what we got to do. But I think some of us are kind of numb to it anymore, which is kind of sad, where our brains are kind of like, "Meh, well, okay, here we go again," but I think it's also a protective mechanism, in the body that we just, and like they say, if they see us fuzzed up, then they're going to get fuzzed up. So we always maintain our calm. So the whole room stays calm type of thing. So, but it's, again, probably protective and just that, it's just another emergency, just another person, and we'll fix it, try to fix it, do what we got to do.
I also think it's important for people to know who might not know this. So, if you're a first responder, so if you're an EMT, if you're a police officer, if you're somebody who's in the ER and you have a case of life or death that's right there, I have heard general population people say, like, why is this person not going fast? Why aren't they running? Why aren't they looking as flustered, right, as the person who's in the emergency or the family member who's watching the emergency? And I think they don't understand, like, you do not want that first responder. You do not want that physician or that nurse or that RT to look like they are rushing in this crazy emotional state of chaos. You want them to be calm. You want them to be collected. And I think that, yeah, it probably is a protection mechanism just from the exposure, but I also think it's a certain level of training to be able to show up to an emergency situation and say, okay, I'm going to be methodical and think on the fly and rely on my training to give this person the best care that I possibly can.
There's a cool little quote out there, and I can never remember how to say it, but like, slow as this and something, slow as simple and simple as slow, something like that. But again, it's all about efficiency. You gotta, if you kind of know what you gotta do, you gotta get it done the best way you can, but you don't have to go crazy. And because when you start going fast and you start going, really you getting fuzzed up about it, you forget things, and things get missed. And so you just want to make sure, we do all the right things. And kind of just to take it back to freediving, when we have a big old emergency on that platform, I really try to, like, calm. It's okay. We're going to get this done because the cameras are on us and everything else. But I really bring it down even to the safety divers who are helping us. Okay, just you know how to do this. We're just going to go through the motions. We just like we did in training. Just take care of the diver, and we'll get there. Don't worry, we'll get there, and it'll be nice and easy. And so I take that back to my, to the bedside in the hospital, just keeping it cool, keeping it calm, get your stuff done. That's all you gotta do.
And also, I think keeping the people who are supposed to be there be there. I remember watching Vertical Blue live last year, and there was a blackout, and I can't remember who it was, both who blacked out or who the other diver was, but it had looked like another diver was really concerned about the diver who blacked out and kind of went in to the safety diver zone, and one of the medics was like, "Get out of here." Like, and I think it's kind of the same thing as family. Family comes into the room and they want to be at the bedside, and they're like, and you have to say, hey, listen, I know you want to help, but you are not qualified or prepared to help in the way that we are. And we need to be in this space to help as best as we can.
Yep. So with last year, that was me who almost pushed that other diver into the water because he was being very intrusive. So my apologies if I said any expletives on the air or anything like that, but it was not the appropriate thing to do. But anyway, but yeah, and sometimes you do get family that tries to intervene, and you just really got to say politely, not sure, stay in your lane, yeah, you're the family member, let us do our job. And the same way with the divers, we're the medical professionals up there, we take care of the divers. If you want to talk to your buddy later on, you can do it over on the beach, but for right now, we got them. So yeah, so we have to try to tell people that too. So it happens.
Well, Liam, it's been such a pleasure to talk to you and to connect with you. And I thank you for your time. I want to ask you one last question, which is, if there was one thing that you would want people to know about their breath, what would that be? If there's one little snippet you could communicate to people, just anything breath or lung or respiratory related, what would you want them to know?
Hmm. well, let's see. First off, never smoke. Do not smoke cigarettes. Don't vape. Nothing like that. Don't put anything into your lungs that's not supposed to be there. There, for one thing. But for the breath part, really, really, I mean, there's something to be said, and I do this. I really do. I'll be honest. When I drive into work every morning, I don't know what kind of day it's going to be, but I take 5 minutes to breathe, and I just stop and I turn my car off and I sit in silence and I just breathe in, I mean, deep breathe, and just, not meditate, because I'm not a good meditator. I don't do that, but just to breathe, to feel the breath. And it is so relaxing. And to me, it sets me up for a good day. It really does. And just 5 minutes, it's all I need. I have a timer on my phone and I do it for 5 minutes before I go in. And I think if everybody did that at least a couple times a day, I think it would be, we would be so much better in, whatever way that it makes you better. But yeah, it's great. It's really good stuff. So I'm so proud of what you're doing. I really am. This is amazing work that you're doing. And it's such an honor for me to chat with you. I really appreciate it. Thank you for your time.
Yeah, thank you. I hope to connect with you more. I have big visions and dreams of getting more breath education to people. If somebody wanted to reach out to you, if they had a question for you or wanted to chat with you, is there somewhere that they can find you?
I'm on all the socials like Instagram, but they can email me, pinklungs@gmail.com. And I'm on Facebook, but it's Lee Bill Baker, something like that. It's my hubby and I. But and I think that's it. I'm on TikTok, but shh, don't say that.
I just started one.
I look for recipes and stuff. That's all.
Awesome. Lee, it's been such a pleasure.
Yeah, thank you. Yeah, and contact me anytime if you have any questions, okay? Even about RT stuff or anything like that, truly.
Yay, awesome. Thank you. Thank you.
All right. Thank you. Have a great weekend.